Good afternoon. Good afternoon, everyone. We appreciate your being here. This is the Appropriations Subcommittee on Health. You're all welcome. We appreciate you being here, and we're about to get started. As we begin, I'm going to ask Representative Buckner if you would open us with a moment of prayer.
Maybe God can hear us.
It's not.
It's up here.
Okay. There you go. Thank you.
Would you bow with me, please? Our gracious Heavenly Father, we're thankful that we're here today to do the people's work, and we ask that you give us discernment, listening ears, and a caring heart so that we can take care of the people we were elected to represent and take care of all of the people in the state of Georgia that we can. We ask all these things in your Son's precious name. Amen.
Thank you. We also, if anyone has not and they want to speak to the committee, there is a sign-up sheet right up here. Please come forward and sign up, and we will work our way through this list as the meeting goes forward. Again, welcome everyone. We look forward to hearing from you and the needs of the people that you are representing, and recalling to everyone's attention that this is for the betterment of all the people of the state of Georgia. And again, we appreciate your time. We're going to begin today with our Department of Community Health. If you would come to the podium, introduce yourself, and please begin.
Thank you, Chair Taylor and the members of the committee. Appreciate the invitation to be here with y'all today. I walked in a little while ago. There was a senior citizens group getting a picture of the steps. I thought I might just get in there with them and just move on, but I decided to show up here anyway. We want to talk about the 27 budget. Want to thank OPB and the governor's office for their interaction with us this year, and of course your House Budget Committee and Senate Budget Committee for the hard work ongoing that everybody does to work together on these very, very complex issues, and appreciate the dedication. And as was already mentioned in the prayer, you know, we're here to try to make Georgia better, and that's our goal.
As you begin, Dr. Burke, I do want to announce we have some seats available. A lot of people are standing. If you want to come and fill up some of these, if you would just leave the first 2 rows open, but please, I hate for everyone to be standing. There are some seats available if you'd like to come and sit down. Thank you.
Thank you. You know, it's probably a mistake to say that the $25 billion budget is boring, but this year's budget is mainly related just to the growth of what we do every day. It's not that complex, but because I am a poor country doctor, I'm going to let our CFO, Cody, go through the details with y'all, and we'll both stand for questions at the appropriate time.
Good afternoon, Chair, members of the committee. As Dr. Burke said, my name is Cody Whitlock. I'm the Chief Financial Officer with the agency. Going ahead and jumping straight into the budget, we always like to level set about $5 billion state funds, about $25 billion total funds, and as Dr. Burke mentioned, fairly straightforward in SFY 27. We always like to level set just to kind of highlight 97% of our budget is medical benefits. This is our beneficiaries, with the majority being our low-income Medicaid population, and our which is a capitated program within managed care, and then your ABD population fee-for-service, smaller population as a percentage, more in terms of cost just due to their acute nature. Going into SFY 27, the The first table at the top is your statewide adjustments, your TRS, billings, DOAS, insurance, et cetera. There is an adjustment to SHBP, the state employer percentage that I will reference later during the SHBP portion, but those are just your standard statewides that's going to be across the state enterprise within every agency. Jumping down to the programmatic changes on your according to your track sheet, the first item, 17.1.6, is an increase for 8 additional Katie Beckett caseworkers. Y'all provided some caseworkers in SFY 26, and this is in addition to that, and very straightforward. They provide eligibility for Katie Beckett. There are only eligibility workers within Medicaid. The remainder of the eligibility workers are over in DFACS. The next item, 17.1.7, is the backfilling that was provided for in AFY 26. This is maintaining parity for caseworkers' salaries across the state. DHS received an increase, so we're making sure that DCH is whole. We've already provided that increase, but just putting that in our base budget to right-size the salaries there. Jumping down, the last position within departmental admin, 17.1.8, is an increase for 1 long-term care manager. This is a position to try to improve quality and update policy for nursing homes to comply with current and future federal rules. The final item within departmental admin, 17.1.9, was some funds provided in SFY 26, $300,000 to help the department submit a state plan amendment related to GME. So that was one-time funds that's just being removed. That state plan amendment has been submitted, and it is just pending CMS approval at this time. Moving down into Board of Dentistry, 17.2.5, one-time funds provided for in base 26, so you're just reducing that. And then 17.2.6 is the criminal investigator. There was a vehicle and some protective equipment provided for in AFY, so this is just that one criminal investigator coming along with the equipment that was provided for in the amended budget. Going down to 17.4, that's our Healthcare Access and Improvement Program, which is SOAR, our State Office of Rural Health down in Cordele. There were some one-time adds in 26, and this is just a sweeping of those funds as they were one-time, and you're just removing that from the base budget. Before we get into the Medicaid benefits, I just wanted to kind of highlight general trends. We're seeing a little bit of growth in Medicaid as a whole. On the next slide, you kind of have a little bit of a breakdown between fee-for-service and managed care. I know that may not look like a lot, but just from a cost perspective, as you will see on the next slide, it does represent some significant dollars. We are projecting kind of slight increases in both of those programs. So within Medicaid benefits, we'll see the same kind of trends that I referenced in amended fiscal year. For the most part, we are continuing to see acuity and growth in ABD, which will represent about $300 million increase in the base budget. In LIM and Peach Care, as I referenced in AFY 26, we assumed a slightly higher enrollment than we actually have when we trued it up to actual, so this is just right-sizing that budget to match the population there. Again, both of those are just in a managed care per member per month environment, so just a small adjustment there. One item that did not occur in AFY that is going to be in FY is your FMAP adjustment. So we're slightly adjusting. It's going to net zero between your state and total funds. It just is your adjustment from 66.4 to 66.63. Fewer state dollars needed because we're going to receive some additional federal dollars there. Going down to the next line within ABD, this is update in SFY 22, the Appropriations Act. Y'all directed the department to update cost reports for the nursing homes, so this is updating to reflect the most recent cost report and the associated costs for the SNFs. Moving further down, you have your dual eligibles, your Part B, Part D premiums, so an adjustment when we have the changes in the federal multiplier. AFY 26 has the same adjustment for SFY 27 as well, related to the high-cost drugs. These are our one-dose gene therapy drugs. We're not projecting as high of utilization as we initially thought, so we're just slightly adjusting that down. So that's the reduction of the 11.8. And the three items that are the reduced FMAP savings for provider rate enhancements, that's a slight adjustment from SFY 26. There were two rates that OPB identified that had a slightly different FMAP, so that's just correcting that FMAP change. And then your final three items are your annual adjustments on your nursing home provider fees, hospital provider fees, and ambulance provider fees. Moving into SHBP, we have a few different items. 17.10.1 is some state funds for House Bill 196. This is the implementation of the NADAC pricing, and so that has been effective January 1. The $1.2 million provided, I believe, reflects the same amount that was put in the fiscal note associated with that legislation last year. There was the $3.1 million for a one-time dispensing fee until NADAC pricing went live. Now that NADAC is live and that legislation is effective, there's that removal. The final two items is recognizing the per member per month increase on your certified and non-certified personnel, going up to $2,028 per member per month. And related to SHBP, this is just kind of a slide showing projected revenues over expense in the future year. As I referenced earlier, we're reducing from 29.454% to 20% on the state employer. That's because we've had sufficient revenues from the state side to cover expense on the state side. With the adjustment on the school side, we're projecting enough revenues there to start contributing to OPEB. Our liability is going to be on the next slide. And so with that, showing the state OPEB, we are fully funded at 131%. Again, more reason for that reduction from the governor's office. And the school OPEB is currently funded at about 11%, and I think they're looking to make significant investments in that. So you've seen that increase year over year, currently at 2028. Chair, committee, that is the budget. Happy to answer any questions y'all may have.
Are there any questions from members of the committee? Representative Aho.
Thank you so much for coming to present to us. I first want to say that I appreciate that this is maybe the most difficult job in government, maybe even more difficult than being in the Georgia State Senate, so thank you so much for the work you put in, and I know how hard you work at this to do good for the people of Georgia. I have a few questions. I'll triage them a little bit because I want to give everyone a chance to ask. A lot of them do relate to some of the federal changes we're seeing with respect to funding and HR 1 and how that's going to change the landscape here in Georgia. So I'll prioritize this question first because I've been curious about this for a while. So our Georgia Pathways waiver expires at the end of the year in December, which is probably fine, right? Because given that the work requirement is going to be federalized, that we don't need that sort of exemption anymore since everyone's going to be doing it, right? We had talked at the last budget meeting we had for the amended 2026 budget about that Georgia's program is going to have to actually change a little bit to harmonize with the work requirements from the federal level, which are actually somewhat more lenient than what we currently have. So given that we do need to amend our state plan to change some aspects of our eligibility cutoff, has there been a discussion about changing the minimum income cutoff from 100% of FPL to 138% to enable us to cover patients for less state money per patient?
You're right that there's a lot of moving parts to what's going on with the federal government and our waiver. And I'll be honest, the CMS's final rules on HR 1 are still pending. And so there are several issues that we don't know the answers to yet. Now, I'm not aware of any movement on the governor's part to change the eligibility on the poverty index that you're describing, but you know, that's something that, like I said, until we actually know exactly what the final rules are and what they mean for Georgia, it's just a little hard to make predictions. But we are in constant communication with CMS. Our waiver was extended last year, and there is some communication that we may have to renew it just for certain legal implementations that don't really affect the waiver itself, but just because of some technical things. So we're still waiting on feedback from CMS on that part of it. And you're right, there is a change in the, I'm trying to remember what the term is, but the child care piece of it, our waiver allows that to happen for caregivers up to age 6, and the federal one, it goes up to 14, so we will have to change that. And then there's another category of eligibility with chronic conditions, healthcare fragility or some term like that they still haven't defined, so we don't know what that will mean as far as the numbers that might qualify for Georgia, but we expect that to increase our eligible people, but it's not based on income.
Do we know from CMS when they're going to have those guidelines issued?
By law, they're supposed to have them by May. Now, my understanding is CMS understands that all the states in the country are kind of in this position that we're in, and my understanding is they're trying to get them out before their absolute deadline, but nothing concrete.
And then just final follow-up on this part of the question is there an openness, given that there will be federal funding cuts across a lot of different parts of the healthcare program, to be open to raising that income cutoff to 138%, thereby allowing us to use less state funds for this and divert it maybe elsewhere?
Mm-hmm. As I mentioned at a Senate budget hearing yesterday, we will support the budget that the governor signs, and so we'll see what's in it.
Thank you. We have a question from Chairman Petrie.
Commissioner, thank you for being here today. I had two questions for you I want to mention. First of all, you've got some in 17.1.6 and 1.7 there. There's some efforts to deal with some, improve some funding and some positions for the Katie Beckett waiver. And I appreciate that, but I wanted to ask you, there was recently a glitch, I'll call it that. You may be able to explain it better, where individuals on the Katie Beckett waiver and a multitude of other waivers lost their enrollment, and y'all fixed that. I appreciate. I contacted some of your very capable staff who immediately jumped on it. But I wanted to ask if you can explain how we can, do we have the staff to make sure things like that don't happen again? It may have had nothing to do with staffing. I don't know the details of this. This just happened. That was my first question. I do have a second question, but we'll take that one first if you don't mind, sir.
Sure. Thank you, Chairman Petrie. We don't know exactly what happened yet. We do have a team working on that. We've hired a third party to come in and do kind of a root cause analysis in the healthcare world. I think they're calling it a forensic analysis in our systems that are supposed to be talking to each other to figure out where in the process that did occur. You know, was it a technology issue, kind of a bug in the software, or was it a human error. We really don't know, but we hope to have that information as soon as possible. You know, as you are aware, these systems are incredibly complex, and it's going to take us a little while to dig into that, but we're certainly want to find
Thank
out
you.
what happened so that we can fix it and keep it from happening again. And I'm not aware of any suggestion that it's related to staffing at Katie Beckett, but you know, there is always been a queue, so to speak, of more people applying than the applications can be worked timely, and so that's part of what this particular budget ask is for us to increase our numbers so that we can get to these.
Thank you, Commissioner. Madam Chair, if I could follow up with that second
Go right
question. So that kind of relates to my second question, and again, it may have nothing to do with staffing. I appreciate that how serious y'all took the issue, most vulnerable people in society, and y'all jumped right on it. Thank you for that. But I do have a question that we've discussed. So this committee here, led by our chair lady, has expressed, even in previous years, long before this current discussion going on nationally, we have been very interested in ensuring that the department have the resources to ensure that we prevent fraud and abuse. There are some positions in here, but not a whole lot. I've been serving people for many, many decades, and more than I'd like to admit, frankly. And I know the department, we're serving more and more people, and we have a department that is really much smaller than it used to be, and because that, and I applaud the efficiency we have as a department. But I wonder if there aren't some positions that we should speak to you about that might help make our compliance side more robust to protect against fraud. Could you speak to that, Commissioner?
Yeah, thank you for the question. Yeah, obviously, this has been in the news nationally of states that they've uncovered some significant fraud in the Medicaid space, and you know, I've asked our team to obviously, you know, talk to their peers that work in other states to find out kind of what they're doing right, and maybe what went wrong, so that we can check our own systems for vulnerabilities. The state has, with y'all's support, invested in some analytic artificial intelligence software a couple of years ago that we're just implemented last year that does a Medicaid claim review, and our number of cases referred to the law department for investigation has doubled since that software went live. So it is doing what it was supposed to do. I think we went from referring about 20 cases a year to over 50. And so I think we'll see more and more fruits, because we're still early in the implementation process of that across systems, because again, as large as our population is, it takes a while to implement these technical software type implementations, and if you don't do it carefully, you have happen what we were talking about earlier with those glitches, as you called it. As far as staffing, you know, we will love to sit down and talk more about what our needs are. We are working on what I would call a mini internal white paper on what are we doing now in the fraud space and in the waste space and in the abuse space, and what are best practices that maybe we could consider adding to what we're doing, and we certainly should have that ready internally like any day now. They've been working on it a couple of weeks, and obviously the governor's office and OPB are very interested in that as well, and hopefully through the process we can let y'all know what our needs are.
Thank you.
Thank you. We have one more question. Representative Buckner?
Yes, I was looking at the enrollment trends and how they're dipping. Do we have any knowledge of why that's going down, and is anything being done to address that?
You got any comments there?
So on an average basis, if you look at 26 to 27, we're actually growing a little bit, just ever so slightly. So I think month to month, there's always these variabilities. retro eligibility of someone coming back on the rolls or then determining they're not eligible. And so there's always kind of a give and take with those. Right now, we're looking at probably, let's call it a 3% trend, if I were to ballpark it, in terms of growth. And that's more or less in line with what we're seeing, and I think even what CMS is seeing on a national basis as well. So although there is the fluctuations month to month, if you look at it over the course of the year on an average basis, it's about a 3% growth.
May I follow up? Thank you. So 3% growth, does that match, how does that compare to the need, the number of uninsured lives? Because that number seems to be growing at a little bit higher rate.
You know, our numbers are driven by applications through our gateway system, and you know that we work, and we don't. Our sister agency DHS, you know, works those applications as they come in, and you know, most of what I know about that the growth or not is based on economy, you know, and what people's conditions are as far as the whether, you know, when we go in a recession, Medicaid numbers grow. When we have low unemployment, and Medicaid numbers tend to flatten out or sometimes go down. So I'm not sure of anything else. I mean, as far as our IES modernization of the systems, you know, we recognize that the application process is burdensome, and that's one of our goals, is to make that process easier, similar to when you're applying for a loan. If you 20 years ago, it might take you 2 months to fill out all the paperwork. Now you can do it on your phone with an app. And so, you know, Georgia's not quite there yet, but we'd love to get to where we can streamline that process. But I don't know that is stopping people from applying. It may make it harder for them to do it.
Thank you.
Mm-hmm.
Thank you. I see no other questions. Thank you. Oh, excuse me, Dr. O, you got one?
I could just ask one more question. Again, it's related to the changes we may see in an HR 1, and I know that CMS still hasn't given their final yet, but I'm sure you're thinking about it in advance. Sorry, this is the last one. So in HR 1, CMS is restricting how states use provider taxes to fund Medicaid, right? So you know this already, but you know it prohibits higher Medicaid taxes, lowers the safe harbor threshold, these types of things. So how do you anticipate this drop in revenue is going to impact the low-income Medicaid, the aged, blind, disabled Medicaid funding, and what would we need to adjust in next year's budget to make up for that hole?
Yeah, that's a great question, and I'm afraid it's kind of in that same wait and see bucket. You know, our directed payment programs that y'all have supported over the years, we submitted, I think, 6 last year before the deadline, and we've heard from CMS on 3. And the ones that we haven't heard from, we suspect it's related to that issue, and we don't know how they're going to come down on those. So if they do restrict our ability to use some of those funds like we've been doing, then there may well be a deficit that we've got to decide what to do as a state next year. There are folks in Congress that feel like that system has been abused by some states in the past, and they feel like it's an issue they want to deal with. And you know, we have felt like we've been good stewards of those dollars ourselves, but we still may end up having to change things because of those federal rules. But again, I think there's, like everything else, there's a push and pull going on, and I don't know what the final answer will be. But I suspect we'll know before y'all leave, just based on what I'm hearing.
And I know you appreciate that as a former CMO of a rural hospital system. Do we have a sense of a ballpark of what we might be looking at? Like any sense of
No,
size?
it would be pure speculation. I think there's people pushing on the complete spectrum, and who ends up winning the day, I don't know. But
As a quick point of clarification on the directed payment, or on the provider tax side, For the budget specifically, hospital providers' fees are not, they are part of that safe harbor threshold, but they're separate and distinct because it's a 1.45% assessment on your net patient revenue. That's already under your safe harbor threshold. So when we're talking about the changes related to HR1, it really, for Georgia, equates out to that directed payment and the impact on the providers associated with the directed payment, not inherently the low-income Medicaid and the budget, just for a sense of clarification there.
Yeah, thank you, Cody. That's very important. You know, the DPPs are actually funded by the hospitals. It's not state funds. Our point is that funding might decrease, and then does the state step in to do anything about that? But because Georgia's been conservative in the use of those, as Cody mentioned, we're not expecting that anything that we're doing on our state budget part of this provider tax is going to be affected, because we're already kind of below those targets that they're talking about right now. So, thank you, Cody.
Are there any other questions?
Please.
Chairman Stevens?
Thank you, ma'am. On the state health benefit plan, the implementation of House Bill 196 looks like it's 1.2 million. Is that just, and I realize it's for implementation, that was such a big change from what we had before. I guess that's baked into the base?
Yeah, it's just managing that system just cost us a little more from an administrative standpoint. There's some, the NADAC, and I know you know more about this than I do, but the NADAC has a number of prescription drugs in its system, but there's a lot of medications that are not in it, and so we have to set up a process to how do we come up with a similar cost structure for those that are not in that database, and so that costs us money, and the PBM also has an extra fee to us to do that extra step that they didn't have to do before that.
Just want to take a moment to thank you for all your work, Commissioner, and your department for this meant a lot. It really did.
Thank you.
Thank you. I don't see any other questions. We appreciate all that you do, and we recognize how hard the department works. You have a full plate.
Yeah.
We appreciate what you do.
Thank you all.
Thank you. Our next presentation will be the Department of Public Health. Welcome, Dr. Toomey. We're happy to have you here today.
Thank you so much.
Thank you.
I appreciate being here, Madam Chair and committee members. This is a relatively short but very positive budget from the governor, and I'm just thrilled to be here to be able to talk about it today. Introducing, as you know, Will Bell, who's our CFO, and who's helping me up here. Let me just start with the governor's recommendations. These are statewide recommendations, and so you've heard about these already. No special clarity around these for public health in general. But the next two items, many of you have heard about. You've heard me talk about it at length. The first, I am very pleased to say that the governor has recommended some additional funding for the home visiting program. You all were the ones who supported home visiting for the first time. And for those of you who may not have been on the committee at that time, several years ago, there was great concern, as there has been for many years, about maternal mortality in Georgia, but also infant mortality, because infant mortality and maternal mortality and outcomes really have to go together. And looking at the Maternal Mortality Review Committee, which we have, which is an excellent, excellent committee that does excellent work, recommendations have been consistently that we implement a home visiting program that at least initially starts with the highest risk moms who themselves have had a prior pregnancy with bad outcomes, who have underlying health conditions or other conditions that may put them at risk for poor pregnancy outcome. We implemented initially with your support, expanded last year, now currently are at 75 counties in rural Georgia, and with the governor's support, we'll be able to expand to a total of 96 counties, 21 additional counties in these high-risk areas. Most have no prenatal care, no obstetrical services in these counties, and this provides these basic core services that will be so critical for a healthy pregnancy outcome. And you can see in the map this addition from the governor, and with your support, would add the pink area to the red area, which are our current 75 counties in rural Georgia. What is unique about the home visiting services that we provide versus others, because there are some federally funded programs, is that we have a comprehensive approach that includes medical assessment. Many of the federally funded programs do not do that, or they're limited in who we can enroll. And this has totally open enrollment for whatever reason that we feel that the mother would benefit from this, and the baby would benefit. We can enroll those family members into this program prenatally as well as postpartum, to at least a full year postpartum. And unlike Dr. Burke, I too started off in rural care, not here in Georgia, but in Alaska. And there are similar programs like this there, which help frame the kind of the development of this program, at least in our minds, and we're able to adapt it to our Georgia needs. And I think that's what's so exciting for me, is this is based on Georgia data, Georgia needs, Georgia opportunities, and in such a short time, we have seen the positive outcomes. In your packet, you'll see there's some a description of the program, but also some anecdotes about some of the positive outcomes we've had, as well as excellent data. And if imitation reflects what people think of this program, Mississippi, who you've heard us talk about, their literacy work and other work have also focused on child health. They are copying our program, calling it the Georgia Home Visiting Program, as the model that they want to implement to improve their child health outcomes. So I think that, too, is a reflection of how quickly others have recognized, both at the federal level and other states, that this is an excellent model that works. The services include clinical assessment, interaction with clinical providers, including the perinatal centers that we now have interaction with in a coordinated way, care coordination, care management, education to the mother and family members, as well as linkage to other important services, not just Medicaid, WIC, Children's First, Women's Health, other medical, as well as literacy education services. So this is really a comprehensive approach, which is unique among these services. And again, it was a Georgia program developed here with input and your support, and I really thank you for considering this expansion. Moving on to the next item is the Georgia Public Health Laboratory, and this is an unusual budget request because it doesn't require any additional funding. It's really just a change in how we look at our budget. Our public health lab, by the way, is the only lab that does many services that public health alone is authorized to do. We have two laboratories, actually here, one in Atlanta, one down in Waycross area. And if you haven't already, I urge you to visit us, because these are really impressive centers for laboratory work that's not a Quest, not a LabCorp, but a unique set of lab services that we provide, particularly and perhaps most importantly, newborn screening. Newborn screening touches every infant at birth in Georgia. We alone are the only entity that do those services, and we'll continue to expand and work to expand it. Thanks to Dr. Burke, who I think has left already, but through his support and the CMS Rural Health Transformation Grant, we're going to be able to expand that work in newborn screening to the Waycross lab as well, to ensure redundancy, so it's not just the lab here in Atlanta, as well as increasing the time, avoiding any time delay between the infant birthing site and the test. And so we can improve efficiency and effectiveness of that program. And thank you to Dr. Burke and his team for working with us on that. The other thing that we do, which is unique in that laboratory, are things like emergency preparedness. We started that really in the Olympics, 1996. Post 9/11 added a lot of bioterrorism agents, continuing to do this work both now and for FIFA, for the World Cup. Again, these are some of the things that are unique to our work here. But what we are doing is just combining the 6 lines that are our current budget of our lab into a single line item. So it's like combining seven checkbooks into a single checkbook. And if you could imagine, it was very hard to be efficient and effective in managing the laboratory work, and particularly because there could be redundancy or missed opportunities for consolidation and improved effectiveness of some of the programmatic funding, because there are all these different sources, and you may not even realize that you were already funded for that. But as simple as this looks, combining 6 line items into a single line was really hard to do, and it wasn't something we could do without the support of the governor and the Office of Planning and Budget. And so I really want to also not only thank the governor, but also Rick Dunn and his team for working with us on this, because that was a bit of a challenge, but we appreciate your support for that very cost-effective change for our laboratory funding. And last but not least, a request for bonds. This is for several of our district health offices in Waycross as well as in Rome, and also the laboratories, both of the laboratories, and this preventive maintenance of these relatively old buildings. And that's it. It's a really nice budget. I have never had such a nice budget to present, and it focuses on prevention, so that's all good.
Thank you very much for that presentation. Are there any questions from the committee? Dr. Al, Representative Al.
Thank you so much. It's nice to see you again. My question's about the home visiting program, which
Yes.
is really exciting. I can tell how excited you are about it.
I was going to
I'm
say,
excited
thank you
about
for
it.
being excited again, because every time I talk about this, it's kind of a joke among the lobbyists. Yeah.
It's great to have a type of program that's
Question?
demonstrated to work and supports
Question?
public health best principles, that is increasingly funded because it helps people. My question was about, we're expanding to new counties and the choice of the new counties chosen. It looks like it's sort of a balance between the highest risk moms, like you said, and also people who live in rural areas that are maybe like obstetric deserts, or they have less availability or proximity to OBGYN care. Given that this is a program that we are growing now and we're looking to the future, looking for ways to build on our successes, what other considerations did you take into account when choosing the counties aside from geography? For example, we know that just because you live in a denser urban area doesn't necessarily mean you have better or increased access to care. Has there been talk about maybe expanding it to some more metro underserved areas?
And we have talked about it a lot, and I think the main point is Metro is blessed in the number of providers. And the Metro, including our perinatal centers and the other hospitals, think of Northside, think of Piedmont, as well as Grady, who is our perinatal center here in Atlanta. Many, many assets here that others don't have, whereas we try to focus on the rural areas with lack of access, lack of providers, but also the highest risk birth outcomes based on both mothers and babies, because I really feel strongly we need to look at the whole spectrum of women's health care, frankly, prior to pregnancy, during pregnancy, and after pregnancy.
Well, I agree with you that in triaging a scarce resource, that you want to prioritize towards the places that have the most deficiencies or lack of care, but just in that we're having successes and growing the program, just to look ahead.
No, thank you. Thank you.
We have a question. Representative Hawkins?
Situation, isn't that within your budget?
Yes, we had some federal funding it was the Coverdale
Right.
Stroke Registry, and then we also have a team that does chronic disease epidemiology. The CDC funding was ended, but we have continued that registry with our existing staff. So we were able to pick up the majority of that work that we had with our existing budget and our existing team.
So you feel comfortable with what you have now to be able to run that program
I do.
and ensure that hospitals keep moving forward in stroke treatment?
We have a very committed staff who are working on that.
All right, Thank you.
And if I hear otherwise, I will let you know.
Yeah, well, I'm sort of interested in that bill since I did that years ago.
Yeah, now I remember.
Yeah.
So,
I see Chairman Petrie. Yep.
Thank you, Madam Chair. Sorry. Dr. Toomey, thank you for this, and I'm so proud to see this expansion of this infant and child home visits. We can have a profound impact on the future of a child when we intervene early like this. You will soon have basically everywhere where you need it, because it's really most needed in certain counties where you have these deficits of other care available. So I just want to thank you for this. This is great news, and that's quite an expansion we're looking at.
couldn't have been done without your support, and for that, I'm so grateful.
Yeah. Thank you.
Chairman Hawkins, you have another follow-up?
I just thought of something else. Now, you're doing these home visits. Do you use cars for that, or do you have a van that actually has equipment to evaluate these patients, or how does that work?
You have cars, and they go from house to house, and have equipment that they to do that assessment in the home,
Right.
including blood pressure, other kind of physical assessments, as well as looking at the home, looking at the other children and the infant too after birth. So there is
Okay.
that, as well as social assessment, and being able to make those referrals, because some of the homes they went to, there were other children, all of them eligible for other services, and they didn't even know about those services. And so this is really an opportunity to bring this information, as well as that medical assessment. That was what is so key about this. And also using community health workers where we
Right.
can, as well as nursing staff, and there's teams. And I think that can provide both the medical and the social engagement that has been so beneficial.
Well, I'll tell you where I'm going, and that is, with our Access to Cancer Care Committee, we heard a lot about, transportation, but also evaluation and that type of thing with mobile units. I didn't know if maybe you could look out into the future and think about that combined with your prenatal care, and maybe combine some of those units, and if we can find some funding for you, and maybe kill two birds. Well, that's not a good word to
Don't say that. We
Help
know.
two birds with one stone.
And I like birds too, so.
Yeah, yeah.
And the other thing, that you all have been very, very supportive of our perinatal program, and
Right.
through your support, we have established, through the perinatal centers, telehealth programs, and we'll be, enhancing that, where in the health departments, these high-risk moms can get some of that really highest risk fetal maternal medicine assessments, through telehealth. And so again, this couples with the home visiting to really strengthen the rural area that have been OB deserts for so long.
See, we wouldn't have to reinvent a model of where these people are and how to get to them and the routes that you take for a cancer screening system also. It seems that we could possibly run that
No, it's
through your
funny
department.
you bring that up, because I just had a conversation about that a few minutes ago, so.
Oh, I missed that then.
No, you.
Before I got here,
No.
on the
but
sidebar.
No, that's really,
Let's talk about that some
we
more
will
later.
indeed.
Good, thank you.
Good, it's on my mind.
Are there any other questions from the committee? I don't see any. Thank you very much for your presentation. We appreciate all you do.
No, thank you.
Thank you.
So much for all your support.
Our next presenter will be from the Georgia Board of Healthcare Workforce. You'll come to the podium, please.
All right. Good afternoon, Chair Lady Taylor and committee. Thank you for inviting me to speak to you this afternoon. I'm Chet Bassine. I'm the Executive Director for the Georgia Board of Healthcare Workforce. High level, we administer loan repayment programs for a variety of healthcare practitioners, operating grants, competitive grants, both for medical schools and residency programs, in addition to nursing schools, and do a lot of supply and distribution studies on a variety of healthcare licensures. I've got our budget presented by by program, I should say, and I will reference the track numbers on the side. Hopefully that will assist. So we have 6 programs. First one is administration. That is the staff, the postage, the mobile devices, all that stuff. There are just 3 statewide adjustments in there. You'll see for the first line, it's 1711.1. It's reflecting an adjustment in telecommunications and infrastructure rates for Georgia Technology Authority, $109 addition. 1711.2 is reflecting an adjustment to agency premiums for DOA, Department of Administrative Services insurance programs. It's a reduction of $52.96. And then last but not least, 1711.3, reduce funds to reflect a reduction in the employer contribution rate for the state health benefit plan, and that's a $62,014 reduction. So that's the administrative program. I'm going to proceed on to graduate medical education from the governor's recommendations. First is 17.12.1. He has put in for 105 new residency slots for totaling $2,096,412. Then next is 1712.2, a reduction in funds for the FMAP, just due to the federal offset increase that's coming, and that is $234,123. And last but not least is 17.12.3, and that's a redirect of existing funds. So it's a $0 item of $734,438 for the Rural Surgery Initiative and Child and Adolescent Psychiatry at MCG at Augusta, and that was from the governor. So that is the GME adjustment, or recommendation, I should say. Next is the Mercer School of Medicine. They have their own program within our budget. That is 17.3.1. This is a 7-year glide path that has been going on. So this is the 7th year it's the final year of this 7-year plan. It is at $12,567 for their campus that they stood up in Columbus several years ago. I will then proceed to the next program, which is the Morehouse School of Medicine, who also has their own program in our budget, and that is 17.14. There were no adjustments for Morehouse. Next is the healthcare practitioner loan repayment. That is all the loan repayments for the variety of licensures that we administer. There was no adjustment in there. That's 17.15. And then last but not least is 17.16 healthcare education programs. The governor has put in 17.16.1 increased funds for medical student capitation for 380 certified Georgia residents at the Philadelphia College of Medicine, also known as PCOM. That is $2,417,940. And then 17.16.2 is just an adjustment to change the name that the governor kindly recommended, and that is just to switch it from undergraduate medical education, because this program does have nursing funds. It's not just for medical students, or UME is what they're referred to, but there's also nursing funds, so we just requested that change. That being said, this final sheet just shows the summary of the original and the recommendations, and I'd be glad to entertain any questions, Madam Chair.
I have a question for you.
Yes, ma'am.
Appreciate all the work that you do and how we've been growing our medical education and your contribution to that. But how were the rural health transformation funds being used to expand residency slots? Are we going to be able to do that in this state? And can we use any of those for fellowships?
Excellent question. Thank
Okay.
you.
It's still kind of new, so.
Very new. As Dr. Burke mentioned, the notice of award came through very recently, so that's good news. We, about 2 weeks ago, announced the residency, maybe 2.5 weeks ago, announced the residency component for the Rural Health Transformation Program. The deadline is this Friday for all the programs. I, out of curiosity, log in every couple days, and we have about a dozen applications in there, and some are for a variety of slots. So I don't have that total. I'm waiting to the end, and what I've seen with any of our grant programs, that at the end they just come in really fast and furious. But we do have about a dozen applications in right now. I have fielded personally quite a bit of questions from program directors and other leadership at GME programs around the state. So once that closes, we'll go through the assessment and the review of whom to award. And then these sites in this existing match cycle, because I did speak with the NRMP or the match organization. So our timings, our dates are aligned with the way they operate. We will be able to inform the sites timely so that they can increase their quota is the word that they use in order to match with hopefully an increased amount of residents. And then they all find out, I believe, the third week of March. So this should happen pretty quickly for the residency level. The second part of your question, if I recall it correctly, Chair Lady Taylor, is more or less the same, but fellowships. I am pleased to state that we will be launching the fellowship component in the next few days. So I want to commend DCH for their collaboration. There's several individuals at DCH that who've been working very closely with me and with rural health, with the feds on submitting the application, and we've got that largely finalized, and that should go live pretty soon. And in similar concept, I've been speaking with NRMP, the match. They also facilitate the majority, but not all the match. Like the residencies, it's like they have everything. But for fellowship, they have maybe, depending on who you talk to, they have the majority, let's call it. So for the majority that match through them, I have worked with them. And then we do have the application written in a way that if it does go outside of the match, there is some ability for some of those fellowships to also apply.
I will say one of the things the committee has discussed, and it is important, is that we can retain these residents. We want to grow our own, and as we're having these residents, we want to promote getting them to stay in Georgia. And we're identifying the needs for these fellowships. The rural communities are reaching out, and these facilities are able to accommodate them, but we've got to get some of those specialties. So thank you for addressing it. I'm glad it's already on your agenda.
Well, thank you.
Does anyone else on the committee have a question? I don't see any, so thank you very much for your presentation.
Thank you.
Thank you. Our next presentation will be the Georgia Board of Dentistry. While you're coming forward, if there are any late arrivals, if you want to speak to the committee, we do have a public comment section at the end, and there is a form up here to sign up if you have not already done so. Thank you.
Operate the computer from down there? Good afternoon, Chairwoman Taylor and members of the committee. My name is Clint Joyner, the Executive Director for the Board of Dentistry and the State Board of Pharmacy. With me this afternoon is Director Stacy Altman, who's our Director of Investigations and the Dental Board's longtime Chief Investigator prior to his promotion to Director. And also with us this afternoon is the Dental Board's President, Dr. David Resnick, to support us this afternoon. We're honored to be here. Thank you for allowing us to speak on the budget for FY25. If it pleases the committee, Madam Chair, I'll be starting with the Board of Dentistry, then I'll pause for questions and then proceed in the same manner with the State Board of Pharmacy. Start with the statewide track sheet items. I won't say too much about these. They've been covered a number of times, but they are included for the Board of Dentistry and for the Board of Pharmacy in HB 94. The Board of Dentistry also has some specific items at lines 17.25 to eliminate funds one-time funds provided last year for protective equipment, and then also to increase funds for one criminal investigator. at line 17.26. We're very grateful for the addition of the much needed additional investigator. However, the Board of Dentistry is requesting funding for 6 additional positions to build out the investigative unit for the board. That is one investigations manager, compliance manager, 1 additional criminal investigator, and 3 compliance investigators. On the chart on this slide, the dark green squares are the positions that are already funded, and then the position that's currently in HB 94 is in the light green. The unshaded boxes are the additional positions that we are requesting. And we make this request to support the board's statutory duty to regulate safe practice of dentistry and to protect citizens in Georgia. We're requesting funding for the additional investigative and compliance personnel to address the board's case backlog and accelerating complaint growth. We believe additional personnel will increase our investigative throughput, help us reduce the case backlog, and restore effective regulatory enforcement, including deterrent value of enforcement. The current concern for the board's investigative unit is that investigative demand exceeds investigator capacity. We're seeing over the last 10 years, we've seen an increase of 17% year to year in complaints. And last year during this same hearing, we predicted that our cases would be at 960 for the previous fiscal year, and we wound up at 1,007. And we are expecting this year that we will be over 1,200. And then we also are still dealing with a significant backlog. What we have found is one investigator closes approximately 20 cases per year. And so with the addition of 4 investigators and then our manager and director, who will also have smaller caseloads, we expect to close about 100 cases a year, or 100 cases a month, roughly 1,200 cases per year, which will give us the capacity to both work down the backlog and to absorb those cases that are coming in. Additionally, we've requested the compliance investigators. The board started tracking all orders for compliance with the beginning of FY25. And as we increase our enforcement with additional investigators, we'll see increased compliance workload. Cases that go into compliance involve long-term probation or obligations that will occur over some time, and so even though we're dealing with 100 cases a month, those compliance cases will stick around for quite some time. We also have found extreme value in pairing criminal and compliance investigators together. You can think of this relationship not unlike that between a lawyer and a paralegal, or a doctor and a nurse, a dentist and a hygienist. They work well with different skills. And lastly, our compliance investigators are not post-certified. And so this has actually allowed us to expand the expertise in our investigations unit. One of our compliance investigators is actually a dental hygienist. And so she brings that knowledge and understanding of how a dental office works from a personnel perspective that would otherwise be lacking in our investigations unit. And so that combination of post-certified investigative police officer specialists and post-certified personnel has been exceptionally valuable to us. Which brings us to the actual amount of funding requested, and this includes the criminal investigator that's already included in HB 974. And the board is requesting an appropriation of $687,102 to fund an additional 7 positions. Additionally, the board is requesting funding for a 3% raise for board staff intended to help us retain our experienced staff and support our operational stability. The board is affected by, especially the dental board, is affected by deep information silos. Some positions have been performed by a single person for over 10 years, and so we're in a position where all of the institutional knowledge for that position is concentrated in one person. We've begun cross-training efforts to begin to break up those silos so we can spread that out, but those are not complete yet to a point that we feel like we would have alleviated that critical vulnerability. And then there's also competitive pressure from other positions out there, particularly in things like customer service. Every company has customer service positions. I mean, private industry and other government agencies. So there is competition to hold on to our people. And our board staff are long-tenured subject matter experts in dental and pharmacy regulations. Our average employee time with the state is 10 years. And so that's the average. We've got several employees who are over 20 years with the state. And so this is a breakdown of which positions for the Board of Dentistry would be affected and the amount of funding requested, which is $18,410.92. And then lastly, which is this is attendant to the build out of the investigative unit, is a scaling request for the law enforcement equipment, which is necessary for our law enforcement officers to do their job. And I say scaling because if we intend that this will scale with the number of criminal investigators or supervisors that are provided or funded. We have also included a request for funding for a firearms safe and an evidence locker, which are new one-time requests because the agency after last year now has state-owned firearms that we need to be able to store safely. And that brings me to the end of the Board of Dentistry.
Let's see if there were any questions. Representative Buckner?
Thank you. I'm always impressed by all the heavy-duty equipment you have to have for your criminal investigators, and I was just curious about the timeline for hiring those investigators and how long, what's the time frame for you to hire those investigators?
This last year, it was a lot longer than normal. We took time after the beginning of the fiscal year to make sure we had policies in place relative to everything from use of force to just all of the policing policies that you need to have in place, which didn't exist before. And then we began our requisition and recruiting process in August, and there was some turnover in HR at DCH, and that led to some delays. We didn't wind up getting our interviews done until December 9th. So our first investigator funded last year will actually start February 18th, or sorry, February 16th. And we had selected 2 investigators out of that pool of interviews, but one of them fell through, and so that position will repost. As far as a timeline going forward, since those one-time delay pieces are now resolved, it should be much, much faster. We also had to develop a process for more enhanced background checks to look at agency internal affairs files and their post files to make sure that we were hiring the right people, because we certainly don't want to put the wrong agents on the street.
If I could follow up, do you have any idea now that they're onboarding about how long it will take for them to clean up some of the, or clear up some of the caseload, backload that you've got?
Stacy,
That's too speculative to know at this point.
No, with a 30-day to 40, 45-day training to get them up to speed on what's what, because there is a huge difference between normal police investigations and these. 30 to 40, 45 days, they will be able to, depending on the types of cases they're assigned, and they'll start with the easier ones and work up to those that give us headaches. They'll be able to, the criminal investigators will be able to handle about 100 a year. That'll start cleaning up what's there moving forward. Processes have been put in place to help clean up the back end, and I'm still working with members of the board on that to clean up what may not necessarily be within their realms that weren't part of a process that is now in place to review them when they come in. So the investigators, to your question, will be able to, in the first year, probably clear up 75 to 100 cases per person. And that's just criminal. Compliance is a little different because they are going to work strict, just standard of care type cases, and those that don't require you to go out into the field. They're also going to work because the compliance folks are going to be dental specific, so they're going to be a part of this industry. Like the one that we have now, we could hire, the purpose of this is to hire people that are in the business so they can help the criminal investigators while understanding what's going on.
Thank you very much. Are there any other questions? Seeing none, we appreciate your presentation. Thank you very much for sharing with us. Our next will be the State Board of Pharmacy.
Fortunately, you're still stuck with me. For the State Board of Pharmacy, the only items in HB 974 are those statewide track sheet items, which, again, have been covered a number of times, so I won't spend too terribly much time on them, but there they are. The State Board of Pharmacy also has, would like to request staffing for an executive administrative assistant and another customer service representative. The need for an executive assistant has become apparent over the last 2 years as the executive director role, and this is a little difficult for me to speak about because I'm essentially talking about myself in the third person. The executive director currently serves 4 roles. It's executive director for both pharmacy and dentistry, and then also legal services officer for both boards. And so at times these strategic higher level functions get overrun by ministerial sort of tasks, things like stuffing envelopes or the like. And I'm certainly not above doing that. I came from a small practice background, and if you had hands, you did what needed to be done. And so that is what has happened, but it's sort of turned Saturday and Sunday into simply the 2 work days between Friday and Monday. Also, the executive director role in the last 2 years has evolved with an expanding scope, increasing engagement with the governor's office, the Department of Community Health, the General Assembly, industry professional associations, and our licensees, really trying to get the board out among its licensees. And the expanded role wasn't taken on because there was spare time. It was because I felt they were necessary for the good of the agency and the good of our licensees and the good of the patients in Georgia. Accordingly, I humbly ask this committee for support in performing this expanded role for the board, for my boards, and for the people in Georgia. Additionally, our customer service department needs assistance. Our most frequent complaint is from our licensees is, I call the board and I can't get through. And so we have one CSR that primarily handles phone calls, and then 2 that handle all the other customer service functions. And that department handles phones, walk-in service, processing of checks, scanning the mail, and then processing all of our service requests. Phones is a massive part of customer service functions, but the rest of the functions in that department do require the 2 CSRs that are currently assigned there. To the phone stats. In a normal month, that's a non-renewal month, our CSRs receive 26.5 calls per hour and miss 23.3 of them. I didn't believe this last statistic at first when I ran it, and so I ran it multiple times, but our phone CSR averages 58 minutes of every hour actively on the phone. I mean, she is taxed to her absolute capacity. And renewal periods see this number of calls double or even triple. And so I ask for the committee to grant funding for an executive assistant and a customer service representative to enable a delegation of some functions from the executive leadership and to protect strategic leadership time, as well as for a customer service representative to help reduce our missed call rate and improve our public access and responsiveness. And to accomplish that, we're asking for an appropriation of $149,176.46. And lastly, for pharmacy, for the same reasons discussed with dentistry, we're requesting funding for a 3% raise for board staff. The reasons are exactly the same. I won't go back into them for time's sake. But for this, the Board of Pharmacy is requesting an appropriation of $18,634.66. And that concludes the presentation for the Board of Pharmacy.
I don't see any questions. We appreciate your presentation very much. Thank you.
Thank you.
Let's see, our next presentation will be the Composite Medical Board.
You want me to sit it down there?
Okay, we're getting this set up. Thank you all for having us again. So the slides, I'm not going to go through all these. I am going to just pick and choose, so I'll let you know the slide number. But I'm Jason Jones, the Executive Director for the Georgia Composite Medical Board. This is our CFO, Roderick Harper. In case I mess up on some numbers, he'll be able to help me. So he'll be here on this. But first I'm going to go through some stats to kind of get you where we're at. On slide 7 is where we're going to begin. So much like our friends with the dental board and the pharmacy board, we also need additional personnel, and this will show you exactly what we're where we're at. So we also do licensing, compliance, and investigations as well. So we're trying to make sure we hit all those avenues. So we're starting off with the compliance cases opened. As you can see, fiscal year 24, 25, and 26, we're seeing an increase in those. Our projected total for fiscal year 2027 is 3,649, and that'll be a 162.14% increase in compliance cases coming to the medical board. And that's with us, people understanding who we are, and what we can do. So that will increase dramatically as we move forward into the next year. So slide 8, as you can see, we have 160 complaints awaiting assignment, so that's our backlog in compliance that we can't touch because we don't have enough personnel to do that. So then slide 10, we'll move on to the investigation side. These are our post-certified officers. The compliance side is our compliance investigators that work in the office, that's similar to our the other board that just spoke. So slide 10 is our criminal investigations, and you'll see that we have 448 in fiscal year 2025, and then moving into 2026, as of this month, there's 185 active cases assigned, and then we have 493 cases pending assignment. So that's things that are sitting there, and we're focusing on the complaints that have patient harm. So we're focusing on them first, triaging our complaints so that we can get those done. But as you can see, we're well over our threshold of personnel and what we can do. So next we'll move into our licensing stats, and I just want to give you these to show you what we have done with the funding that you did give us and the personnel that you did give us, and you'll see the impact, because we've been focused on licensing more so than others, just to try to get that up to speed. With our new licensing system, you'll see the numbers as we move forward. But physicians' licenses have grown. So Georgia's active physician population grew by 7,333 since fiscal year 24 when I took over. So we've had this many more physicians come into the state to practice. And then fiscal year 26, the estimate will continue to rise to maybe around 55,935 if that trend continues. And that'll be an additional 4,218 licensed physicians. So we're looking at more physicians, we're licensing them faster, and getting it done to bring them into the state. So slide 14 is just the physician renewal. Not really going to go over that, but renewals are increasing because of the amount of physicians that we're licensing. So that's also increasing, and also taxing load on our staff. So this is some good news on slide 16. This will show you what our new license system and our new processes did. So from 7/1/2024 to 7/1/2025, before the implementation of our new system that you all funded, it took about 150 days to get a license for a physician. Since we've implemented this new system, it's around 50 days. And I want to get it to 2 weeks, but we'll talk about that in just a bit. So we are improving on these numbers as we move forward. APRN protocols, that's been a sticking point that I'm sure you all have calls about as well. So from 24, 25, and 26, in 2026, we've actually surpassed in 6 months what we've done the last couple of years. So we're looking at APRN protocols approval in this coming fiscal year to be about 7,197, which is almost triple what we've been doing. So this process is working, and we're approving more APRN protocols so they can be in the workforce as well quicker, and that'll be about a 73.89% increase from fiscal year 24. So we are moving forward with what you've provided us so far, and we're using that funding to get personnel to be able to do this and technology to be able to do this. So on average, the same timeline with the physicians prior to, I'm sorry, this is slide 19. Prior to the implementation of ThoughtSpan, on average, a protocol took 120 days. After implementation of this system, it's taken 20 days on average. So we're getting them quicker. Sometimes it's the same day if they have everything in there. So we're getting things quicker with that as well. And we and that's just with 3 APRN license techs. So PA is the same. Like I said, we're increasing the numbers by what we're doing. Slide 20, it'll show you we've increased it 28.17% as far as the approval rate. So we're getting more PAs in as well, physician's assistants, to be able to help with that medical shortage. So slide 22, this is the total that we have up to date. So we have almost 70,000 licensees within the state, with physicians being the most, with 51,717. So each year we've increased. So total license increase since fiscal year 24 is 9,924 additional licensees that we've been able to bring to the state with all of these professions. Physicians, physicians was a large part of that amount, but this doesn't include the APRN protocols, though. This is just for the licensing count for the professions that we regulate. So slides 23 through 39, I'm not going to go over, but those are things that will give you, it'll show our workload and then the number of personnel that are recommended for that workload based on the number of calls, emails, and applications that we receive. So now we're getting into the reason we're here is slide 41, and that's going to be our finance. So we do keep some retained revenue. On average, it's $1.3 million, and that goes to operations for rent, for vehicles, for items that the staff needs, just different things to pay peer reviewers, medical directors that we have. So we use that pretty much, drain it to what we need. So that's for our operations. So what we remit to the state treasury is on slide 42. On average, it's about $9.3 million in fees that we accept and then remit to the state treasury. This year, it's looking like we're going to estimate about $11 million in revenue to the state through the funding, through our increase in licenses and processes. So we're increasing those fees because we're licensing more. Slide 43. So this is the governor's recommendations. So we're on, we forgot to put that in there, I apologize. 17.17 on the governor's recommendation sheet. This will be what is recommended. So state funds for 44 staff is $4,051,539. Georgia PHP is funded $500,000. We're losing the safe haven funding, which we'll talk about in a bit. And then the total state funds is $4,551,539. That's the recommended budget from the governor's office. The one to the right is what GCMB is asking for based on our statistics and the need to make sure that we're hitting the avenues that the state needs and what our medical professionals need and our citizens. So we're looking to hire 21 additional staff members, and that goes across the compliance, investigations, and licensing realm. So we did have a couple of plans that we were thinking about. So if plan one, if we could get appropriated 88% of the average licensing fees, we wouldn't come back to you, we wouldn't ask for anything. This will take care of what we need to move ahead and make sure that we're staying current with those numbers that are increasing, because we don't want to fall back. You know, our staff is really working a lot. They're taking on a lot more than the average. So a lot of us work the weekends to try to make sure we stay ahead. And I don't want my staff to continue doing that. That's a burnout thing that causes turnover, and we really don't need that. But plan two is just that we increase some of the fees by $100. And that will probably be the renewal fees, because we're amongst the lowest in the states on renewal fees. And that'll be, a board decision to see if we can do that. But if we do that, then we can retain some of that money, but we're also giving back to the state some additional revenue as well. So, and we're not causing a big burden to the licensees with that, because it's every 2 years. So $100 every 2 years, $50 a year, that they would be able to do that. So we're asking for, I know it's a large number, $8,170,650 to be our total, and that's an additional $3.6 million in order to get that personnel. It'll all go to personnel to be able to help with what we're doing. So we do have retained revenue, slide 44. We did, me and Terodrick sat down and figured out we could use some of our retained revenue right now without breaking the bank, and we actually hired 6 positions to be able to help with us staying current and get ahead. So we're thinking outside the box to try to use this, but this isn't a long-term solution. This is a short-term solution, because in 2020 or 2030, this funding will dwindle, and we won't have it to be able to fund these positions. So that's why we're asking for that additional money to be able to help fund those positions as well. Slide 46 will show you the org chart and kind of where we want to be. This will help keep us current and get us where we need to be. So that'll be adding a total of 21 positions. So we'll be up to 71 personnel. Slide 47 is the listing of the personnel that we are requesting. And you can just peruse through that if you'd like, but that's the 21 that we're requesting. The last one, the medical director, is contingent on the international trained physician bill, because we'll need a medical director to oversee that project. If that doesn't pass, then we're not going to need that medical director. But if it does pass, we will need funding for a medical director. So slide 48 is kind of what we're doing for rural health and trying to get more involved with that as we move forward, because we see that we can do that and help out. But we have been in talks with the Technical College System of Georgia. They're willing to give us office spaces within areas of the state in the rural area so that we can employ, based on some of these requests, we can employ licensed techs and compliance specialists in a dual role that will be in those areas, so that people can go to them with any issues or questions or complaints instead of having to rely on the Atlanta office for everything. So we'll be in the communities. We'll be able to go out and help train people on the licensing system, whatever we need to do in those communities to help out to kind of expedite some things and expedite licensing as well. And then the safe haven funding, we are requesting that be reinstated this year so that we can continue serving the rural areas and the practitioners in the rural areas, so that they don't have the burnout. If there's a shortage, we know they're stressed. We know they need some help, and this program offers that. And we've been able to enroll I hate this number, 666 physicians within that program. So it's working. It's doing good. We're going to get statistics on that, hopefully, so we can share that with you. So slide 49, these are the proposed legislation and physical impact that GCMB will have if these legislation items do pass. So that's just something that if you have any questions on them, I'm happy to answer. But these are some positions that we will need and funding we'll need. So slides 50 through 58, I'm not going to go over. Those are things for the positions that we're requesting and why we're requesting it. So that can give you more information on why we need them and what they're going to do for us. Slide 59. What we're requesting is state funding to support 6 positions that we currently fund through our retained funds, and then have additional funding for 21 new staff positions with a pay increase, because they haven't. We need to make sure we're paying them a good salary, because losing that knowledge puts us behind even further. And then to fund the Georgia PHP and Safe Haven programs. And then the total projected expense is $8,170,650, which we do remit more than that in funds from the fees that we do receive. So that's our request, and there's a lot of stats to look over. So if you have any questions, I'm more than happy to answer them.
You do have a couple questions. Chairman Hawkins?
Congratulations, you talked as fast as a New Yorker with a southern accent. Tell you what, that was a lot.
I've
You
tried.
talk about increasing the renewal fees.
Yes, sir.
What are they now, and what increase are you looking at, say for physicians?
So physicians, it's $230 right now, and we did a UGA study, which you all have, that'll show we're the lowest in the states around us.
Right.
But we're looking at about a $100 increase
And
in a
that-
renewal
what
fee.
is
on-
that, a biennial?
Yes, sir.
Yeah.
Every 2 years, yes, sir.
Right, okay, how about nurses? What kind of
So-
license fee for nurse? Oh, that's right, you don't
Yeah,
do
no,
nurses.
sir. We just do the APRN
That's
protocols.
That's right, excuse me, that was a dumb question, I'm getting tired. Okay, that sounds good, thank you.
Yes, sir. Thank you.
Leader Hughley, you have a question?
Thank you, Madam Chair. Thank you so much for your presentation. A couple of questions. Number one, this 160 plus complaints that are awaiting assignments, what is the impact of that on the citizens of our state?
Well, I think it's a major impact because we're not giving them the resolution that's needed in a timely manner. Same with our medical professionals. If they have a complaint over their head, it could cause issues with their practice because they're thinking about this complaint being resolved. And the same with our citizens. You know, it takes time to do these investigations to make sure we do them right, but having 160 complaints on the compliance side is hard on the citizens because they want resolution as well. And it may be a serious incident that happened, and now they're trying to get resolution, but you know, with lack of personnel, it's hard to keep up.
And the other question I have is this, I think that I saw a salary, I was trying to keep up with you going so fast.
Sorry.
But $45,000 is the salary for some kind of technician?
So licensed techs are $43,500 a year is their salary, and that was raised in 2024 when I first came on. It was 36 or something like that.
And
So
these people live and work here in Atlanta for that?
yes, ma'am. Yes, ma'am.
All right, and the last question, if given what you're asking for, what would be the results in terms of the complaints, in terms of the efficiency of licenses? What could we expect if you got just what you asked for?
It's the same as what I showed you with the licensing. The timelines will decrease. We'll adjudicate more with that. So our licensing system is also going to be our investigative system. So complaints will go into that. Right now it comes into email, and then we have to put it in 3 different places. So once we streamline that, you'll see the same outcome as you do with the licensing. Everything will be expedited. I don't know the number because we haven't done it yet, but just being a case manager myself, as a criminal investigator myself, if you have the tools to do it and you have the people to do it, it'll streamline tremendously, and we can get that backlog down.
Thank you. Chairman Stevens, you have a question?
I do. Thank you again for the turnaround number. It's quite a jump from the lag that we had before.
Yes, sir.
Can you tell me, since you moved from the Secretary of State over to being under the DCH, I don't know of any other board that has retained earnings that you can keep the dollars within the composite medical board. All the rest of them turn it back in. Do you know what that total number is that you've retained since
I've only been here 2 years, so I'm not sure, and we're trying to get a baseline because we didn't have one before. So that's what we're trying to keep track of, our retained funds now, and the 1.3 is on average of retained funds
per year?
And it doesn't come from the licensing; it comes from other fees that we charge: wall certificates, wallet cards, APRN protocols. So it's not a license; it's just a other that we retain those fees. And I don't know when that started, but I know we have it, and we're just trying to utilize it the best we can and try to figure out a baseline.
That's per year, 1.3
on average per year. Yes,
per
sir.
year.
Yes, sir.
Representative Buckner, you have a question?
Yes, ma'am. Thank you. When I looked through here, it said that you have like over 25,000 offices to inspect or evaluate, and the number of licensed physicians is almost 56,000. We also do a lot of work on medical education and making sure there's funding for doctors, and we're trying to make sure that they stay here. What number are we trying to get to for an adequate number of doctors for the state? Do you have any idea?
Just from a brief study that I did, I mean, if we're looking at 51,000 or so, I would think 80 to 90 to compete with the other states, according to, you know, I think the Medicaid data and things that I've researched. So North Carolina's comparable to us. We would like to be, you know, 80, 90,000 physicians, not including the rest.
Got your work cut out for you.
And that's why we're building the relationships with the other agencies, to see how we can all work together. You know, Chet and his team, DCH, Technical College of Georgia. How can we better recruit and help you recruit? Because that's not our duty really, but I think it is our duty. So we're trying to figure out how we can better do that to better meet that. Yes, ma'am.
I have a quick question. How often we're talking about physicians, have to renew their license, and what is that process?
So every 2 years, we've kind of automated it a little bit better with our new system. So as long as they meet certain questions they answer, and they meet the citizenship requirements, and they don't have any adverse actions, then it's usually a fairly instant process.
That was one of the things. What do you specifically look for? And is there a new background check, or is it just, are they still employed the same place? What do you look at?
So we have a questionnaire that they do. Have you had any, have you been arrested? Have you had any sanctions on your license in another state? If you answer no to those, you're a U.S. citizen, and you haven't had any issues, then it's an automatic process. If you had some issues, then it gives us an alert, and then we look into that and see what else is needed. So that renewal could be prolonged, but we don't require another background check, but the initial license is a background check, which is a fingerprint check, but we don't require it on renewals.
Along, I guess it's similar to that, but what kind of outcomes? I think we may have presentation later, but the wellness programs that we put in last year, have you seen good results? Have you referred people?
We have.
Are they working well within your department?
We have. So with the Safe Haven, we've had a good impact with the 1,666 enrollees. We have specific information for what programs they have been entered in, but that we may not share right now, but the PHP has also seen an increase in enrollment, 46% increase in enrollment with what they're doing. So both programs are doing good as far as helping our physicians.
Thank you. Dr. Au?
This is not a question, but just to fill out your answer. Also, the other things that I appreciate in terms of relicensure that the Composite Medical Board asked for directly relates to keeping track of our medical workforce in this state. So in addition to looking at all the background screening and so forth, they ask, do you work in a hospital-based system? Do you accept Medicaid, Medicare? Do you speak any other languages? What % of this type of patient, that type of patient do you see? And are you looking to retire within the next 5 years, something like that? So that's actually really great that they force us to go through this every 2 years, so we can keep track of if we're losing doctors, if we're looking to have attrition in the near future, and what kind of populations we serve. So thank you for keeping that in there.
And Chet asks us for more every time. I don't know where he went, but we do get a lot of information.
Chairman Stevens?
I'm not sure if I missed, were there any increases in PA's fees, licensing fees?
No, sir. There hasn't been any increases yet at all. We don't want to increase, but we're looking at options to see how we can if we need to.
Thank you.
Yes, sir.
I don't see any other questions. We appreciate your report, and we are going to take a 15-minute break. Thank you.
Thank you.